I'm going to continue with abdominal aortic aneurysm management via endovascular. Because all of you are experts in EVAR and we're running quite on time, you've probably all done at least 50 EVARs at this point in your first 2 months, so I expect you all kind of fly right through this. So when I talk to patients about, explaining what EVAR is, how do you really explain endovascular aneurysm repair? And I try to give them a little bit of a real-world answer as soon as we get the slides up. So what I tell them is that imagine you have a tire and there's a hole in it. You have basically two options. You could treat it open, which is basically you have a bad tire. Well, then we just put some sweet Pirellis on it, brand new tire, take it out, put it back on, good to go, no problem. Or you can do endovascular. And basically endovascular repair is getting one of these, unrolling it, stuffing it inside of the bad tire, and then inflating it up to fill. So you're not really fixing the tire. You still have the same tire. It still has a hole in it, but now it has an inner lining where the blood is now flowing through. So clearly, if you don't pick the right case, you have a setup for failure, so try not to fail. If you start out with a tire like this, you can put an inner tube in it, and you can inflate it, but odds are you're not going to get very far before you run into trouble. So case selection when you're doing EVAR is very important, so try not to fail. So what do you have to do when you're considering? You first have to start out with a good indication, right? So we often talk about a size criteria as the way to determine whether or not somebody should have an EVAR, but the reality is that size in and of itself makes a lot of assumptions, and that's that the risk of the procedure is going to be lower than the risk of leaving it alone and watching it. There's going to be certain patients that are just so high risk that it doesn't matter what you do. As one of my teachers used to say, that guy won't tolerate a haircut. So maybe EVAR is not a good option. You have to be able to get the graft in. So if you have really, really tortuous iliac arteries, you're going to struggle getting that thing in, and you're going to break stuff, and you're going to get into trouble. So your access vessels, your terminal aorta can't be too small. If your terminal aorta is too small, then you're not going to get your limbs open. You're going to get stuck. You're not going to be able to cannulate your gate, and can be a mess. The endograft has to seal at the top. You can't have a neck that's too wide. I found this on the internet, and interestingly at the bottom it says copyright SVS. And I didn't know that SVS had a Korean edition, but if they did, I find it odd that they recommend that that's your sealing neck. So clearly if you're there, you're going to get an endoleak, you're not going to seal. So avoid these juxtarenals and sort of wink one eye and say I can get it in and I can bill for it. The endograft has to seal at the bottom. You have to make sure that your iliacs can't be too tortuous. If you end on a bend, it's going to occlude. If they're too big and you try to hope it's okay, odds are over time that aneurysm is going to get bigger in the iliacs. And of course, the graft has to last. It has to last just a little longer than the patient is going to last. And if you can get to that point, then you win. They didn't die of an aneurysm rupture. So it can't slide down and it can't occlude. So one of the things that you'll see now is all these barbs and stuff that are put on to keep the grafts from moving. And then the other thing to consider that a lot of people don't do, particularly proceduralists, is to make sure that you don't cover vital or critical vessels. And all of you know that you don't want to cover the renals and you probably don't want to cover the internal iliacs, but sometimes a good vascular surgeon is a good clinician. And you'll see that this patient is living off of the inferior mesenteric artery and a very stenosed SMA. So if you go in there and put an EVAR without thinking about that stenosis in the SMA, or God forbid you actually embolize because, God, that IMA is really big. We better, get rid of that right now. Next thing you know, the patient will present with chronic mesenteric or even acute mesenteric ischemia. And most of the professors in the room have probably seen that more than one occasion. So avoid that. Look at your imaging carefully. So the principles are, interestingly, it was first reported by Volodos, who was a Ukrainian surgeon who really had some really awesome publications from the late 1980s where he did EVARs and TVARs and dogs. And he published all of this stuff in Russian publications and unfortunately doesn't get a lot of credit, although it's commonly first attributed to Prodi in 1991. Volodos is now dead, but I'm sure he would have cared. Anyway. Originally, the first things that we started doing is you'd have these perfect aneurysms, the so-called apple on a stick, where you had a good neck at the top and you had a good neck in the terminal aorta. And we used to hand sew a little graft on a stents, and we used to pop them open in a straight line. And those were the only aneurysms we could treat. But then over time, we figured that we could actually go all the way into the iliac, and then we can occlude the other iliac and do a fem-fem bypass, which is sort of a modification of what you see here. Now, of course, we have modular grafts where we can reconstruct the whole aorta from top to bottom in a sequential fashion. So you're going to see, I made this just for you. it's actually a beating aorta. It's not a series of pictures that have been stitched together as best as I possibly could. It's actually going to move a little bit because it's the aorta moving. But you're going to put you put the graft in on one side, you slowly uncover it where you want it. You're going to watch for your renal arteries. You make sure that you go below that. And of course here you're watching your iliac artery. You find the gate, you get inside, you stuff it in, you deploy the lower part of the graft. Ideally you want to put it above the internal iliac bifurcation, and then subsequently you finish. And that's a traditional modular graft. There's one brand that doesn't do this, which is Endologics, and I'll show you a little bit about that. So this is sort of like the gamut of American available endografts, and if you notice in the bottom center, there's one that has a long center here and then a bifurcation, but the rest of them are all short with long legs. And Endologics apparently reportedly originally tried to be like the other one, but apparently it fell down and sat in the bifurcation, and they said, that looks pretty good. And then they decided to change their setup and reconstruct the aorta. There's another one called Endoleaks, which isn't on the market yet. But anyway, these are the different types of things. Now, the other cool thing is that in your generation of training, you have these modern endografts, and we have iliac branch devices to treat when the common iliac artery is aneurysmal, we can extend down. In the rest of the world, literally, there's 2 companies at least that you can get these in the United States. We just have Gore. But the way you put this in is you go inside, then you get up and over the bifurcation, you find the internal iliac, you get through it, you cannulate it, and when you're done, you pop it open into a regular endograft, and you can reconstruct an iliac artery aneurysm with Endovascular, which is pretty cool. And of course, the true future, probably within the next 5 years, all of you will be opening off the table. When people talk about fenestrated endografts, that means they have fenestra, they have windows, they have little holes. And when you talk about multi-branched, is that these little branches. And the idea is that the branches are downward facing so that you can sort of like easily sort of cannulate in there. And this is probably the future of the off the shelf, where you can sort of open a standard endograft that will cover about 70% of all aneurysms. And you can actually treat, as you can see here on the far right, the entire thoracoabdominal aorta with endografts in today's era. And it'll be certainly your reality. And back in the day, we used to have to like take out the endograft and make holes in it and sew little rings on it and then stuff it back in and then try to make sure that it lines up. And nowadays, they're just so beautifully marked that you can do this with a whole lot better ease. So things to worry about. Remember, you're just sticking that inner tube in there, the concepts of endoleaks. And I'm sure most of you know these, but ideally, think of a type 1 as a seal zone. So the proximal is a type 1A and the distal is a type 1B. A type 2 endoleak is that once you've filled this aneurysm with something, the branches coming out of the aorta are still there. They can leak back in. Remember this from a test perspective. The most common source is the inferior mesenteric artery. The IMA is going to account for 80% of your endoleaks, and number 2 is going to be your lumbars. So IMA is the most common. So if you ever have an endoleak and you have growth, worry about the IMA. Graft joints is type 3. When you put the iliac into the main body and you have a leak because it didn't seal properly. A graft type 4 is sort of a historic. I put it in here old school. Back in the day, the fabric was very thin, so the blood used to shoot in between the fabric. Nowadays, you might see a so-called type 4, which is at the suture lines. Remember, these are hand sewn, so in the little holes where the sewing was done. And then a type 5 is basically, I have no idea where it's coming from, or a so-called endotension. You have an aneurysm, it looks perfect, you did 50,000 CTs, you have no idea, you don't see contrast anywhere, but the aorta is still growing, so you know that it's under tension. That's called a type 5 endoleak, and here's a schematic. So interestingly, if you look at the 30-day mortality of doing an EVAR, it's negligible. It's less than 1%, 0.5%. Nobody dies from an EVAR, as long as you follow the IFU. However, randomized controlled trials will show that this lower mortality that you find early with endografts, and they also have shorter length of stay, interestingly, after 5 years starts to disappear. So if you look at these 2 bottom lines, this is the likelihood of somebody having some degree of complication that includes endoleaks over a 4 to 5 year period is about 40%. And then back in, at least in EVAR 1, which is people that could have open or endo, 20% of those people would end up with some sort of intervention. So if you look here in the open, the likelihood of you having a complication is pretty uncommon. The likelihood that you actually need something for it is also uncommon. So open does have some degree of benefit. And the best part about it is if you look at the sort of survival, this blue is the survival for open, and initially a lot of more people will die at the beginning, but over time, if you can make it through the surgery, you generally do pretty well. But if you get EVAR, you're less likely to die, but over time, somewhere around like 5 to 6, somewhere between 5 to 7 years, eventually people will die, although usually it's not from anything to do with their aneurysm. So what we're finding is that the long-term benefits are really sort of equal as far as survival. And of course, EVAR will lead to more procedures and more imaging and more things like that. So it's better in the front end, but it's entirely possible that maybe open surgery might be better for these sort of low-risk young people, because in the long run, they're probably going to do better and require less stuff. And if you look at the likelihood of people, if they have no complications from open repair, they will probably do well for a survival perspective, whereas people who apparently have no complications in the beginning will eventually sort of catch up. So patient selection criteria: you want a good neck, you don't want it to be angulated, you want distal good iliacs, you want a nice narrow neck, and you want to have iliac vessels that are a good size. And if you have all this, you can look at, I'm just going to skip a little bit. If you have all this, it was studied in the circulation paper, and they said, okay, let's look at people that followed the IFU, and let's look at people that didn't follow IFU. And the outcomes are really kind of interesting. If you look at the likelihood that the aneurysm is going to grow, 41% of the patients would have some degree of growth of the aneurysm. So, almost half of the people if they didn't follow IFU. And within the group of people is that if you had an endoleak, if you were age over 80, if your neck was, relatively large, so in the 28 range, remember 32 is kind of your upper limit. If you started out with a big neck, chances are you're going to have growth if it was very angulated, or if you had large common iliac arteries. If you stayed inside of the IFU, the likelihood of you not having enlargement was a lot better. If you went outside of IFU, conservative IFU, you're going to have growth. So I know what you're thinking. You're thinking, yeah, but we're so much better than they were back in the day, and we're so much, better grafts and better stuff. But interestingly, you think that you're unstoppable with the new grafts, but the reality is that if you look at the timeline, back in the late 90s and early 2000s, when we really were scared about doing EVAR, the likelihood of you having enlargement was a lot less. But as we got more familiar with the device and started stuffing in people that maybe we shouldn't have, you actually have increased growth. So just because we're better at it doesn't mean we're actually having better results. So here's an example. You have a 19 millimeter neck, and somebody, the IFU would say oversized 10%. So that would be 19 millimeters, 10% is 1.9, so that'd be about a 22, 24 millimeter graft. So what happens if you don't read the IFU and you put a 32 millimeter graft? Well, a month later, there's your 19 millimeters. This is what happens. Eventually, it'll grow and grow and grow and just rip open. So why did this happen? It could be that you just didn't follow the instructions for use, but the reality, so this patient ended up with an open conversion. So were you too cavalier? Did you just not have enough stock, or you just can't read a CT scan? Remember that a CT scan basically cuts you in half like a loaf of bread. The cuts are going to be perfectly perpendicular. So if you cut straight across an aorta that has an angle, it's going to look like a long oval. But then if you actually turn it and angle it the way you should, it's not going to look so big. It's actually the true size. So you may oversize because you're looking at it the wrong way. So make sure that you look at things from every particular angle in the direction, and that's where we always talk about getting 3D reconstructions to really know what's going on. And you can use whatever series you want. Worst case scenario, look at coronals and look at sagittals. So look for everything, go from the top to the bottom, look for calcification, be careful of heavily calcified vessels. That's a great way to just shove something through it and it looks great, you deploy, and then when you take your sheath out, next thing you know, you've destroyed the iliacs and you had no idea. For small tortuous vessels, you can stuff them in, you can do different things, you can dilate it, you can do whatever, you can use a conduit. And just because it doesn't fall in the instructions for use, everyone who's in here who's teaching you today clearly believes that the IFU is for beginners. So if the iliacs are too small, you can make them bigger, you can do open, you can do a conduit. What you do is you do a retroperitoneal exposure, you stick a graft in there, then you can shove it inside the graft and it goes. Or if you really want to be brave, you have tiny little iliacs, no problem. I have big stent grafts. I can blow some stent grafts in, and next thing you know, you can get through that now. I'll skip a little bit here, but basically be really careful. Stick to the IFU, you have better results, or get ready to deal with the complications. Thank you.